And then we'll get started. So welcome out, everybody. Good to be with y'all again. Hope you're all doing well. It looks like a lot of you are turning in your assignments and working on your tests and getting things done. So that's great. I appreciate that. I'm going to go over just a couple quick things at the beginning. This is probably our longer lecture for this particular class. We're going to get into a lot of the good meat of what we do in nuclear cardiology. But a couple things I wanted to go over really quick. There was a couple of questions on submitting some of your assignments, specifically test corrections. So I just wanted to quickly share my screen and kind of show you what that looks like on your Canvas. All right, so can you guys see my Canvas open there?
Yes.
Okay, thank you. I'm like, you guys can hear me, right? No. Okay, so to submit anything, most of the stuff is everything you need to submit is going to be located under assignments. So if you go into assignments, and this should look just like yours because I'm in a student view, you'll see that you have your places to do your sections and also your test corrections. So if you go in under the test correction link, for example, it should bring up this page here, and right under choose submission type, it allows you to either just text right into Canvas if that's what you want to do, which isn't the most ideal for trying to do a document, or upload another type of document. So those two options should get you in there. So if there's any confusion for any of you, that should show up. If that doesn't show up on your Canvas, then there could be something wrong with your Canvas. So if you don't have that, will you please let me know in a message, and then I can reach out to somebody up at Weaver and try to figure out why your Canvas doesn't have that, because it should. So that'll be how you do that. So hopefully you're all good on that. And then one other thing I'll show you on here just to kind of remind you of what's coming up. The rest of from here forward, things seem to kind of go really quick to the end of the semester. So just as a reminder for semester dates, today's March 20th, we're going over section 2, myocardial perfusion, so that's 2A, and then our next class is April 10th, so it's actually a little quicker than the interim periods that we've had in the past for the rest of the class. So for that one, we'll be doing viability, amyloid, and PET. And so again, just know that that's coming up pretty quick, and then everything will be due, including the last exam, by April 26th. So just kind of wrap your head around that. Think about that as you progress through and as you kind of give yourself time to get everything done. Okay. All right. Any questions on that? If not, we'll move on because we got a lot to cover. Okay. Let me stop sharing that. And let me get my slides going and we'll get moving here. Let me do it. Okay. Do you see just the slides, or are you seeing like my whole desktop?
Whole thing.
Okay. Sorry, let me try that one more time. For some reason, it wasn't giving me the single option, which works a lot better. Try that again. How's that? That look better? That look like you're just seeing the slides?
Yes.
Okay, thank you. Let me just move you guys out of my screen. I'm not staring at you. All right. So like I mentioned, this is section 2A, and this is going to be kind of the big meat. I will tell you from the outset, I'll probably go a couple hours on this. So again, I believe you guys have Brandon's class after this. Correct me if I'm wrong. But as I've done before, like don't skip Brandon's class to finish mine. I've got the recording going, and I will finish the class. And you can come back and look at that last part. Of course, if I'm not your dad, I can't tell you to stay or go, but I don't want you to miss Brandon's class for that. But I'll just finish and make sure everything's included for you guys. So this is going to be myocardial perfusion. So we're going to talk about stress testing today, and this is like the main thing that we do in nuclear cardiology. A lot of these other tests we do a lot as well, but they're kind of to the side of this is our main meat, right? So this will be a good discussion today. So I want to start out by kind of asking a question to you guys. So we've learned about MUGA scans, which is cardiac blood pool. Today we're going to learn about myocardial perfusion. So my question is, what is the difference between those two? Anybody can answer.
Well, on the cardiac blood pool, you're looking at the ejection fraction of the left ventricle, whereas on the myocardial perfusion, you're trying to see if there's a lesion on the left ventricle.
Okay. Okay. I like that. Anybody else want to add to that? You're definitely along the right path. Those are some of the differences we're looking at for sure. Let me I'll throw up a picture here. Anybody else who wants to add to that? I know you guys are like, what's he doing? He's forcing us to talk. That's not normal. Who else wants to be brave? What's the difference here? Nobody is going to do it.
Perfusion is looking at the heart muscle itself and if it's getting any blood, and the MUGA is looking more at the flow of the blood through the heart.
Yes, excellent. That's very good. Who was that? I didn't see it popped up.
It's Janine.
Janine, thank you. Thank you both for participating. That was awesome. So yeah, I mean that's the real idea here, that blood pool is circulation through the chambers, just like you said. And then myocardial perfusion, we're actually looking at the blood flow to the muscle of the heart. If you break apart the word myocardial perfusion, myo is muscle, cardial is heart, and perfusion literally means the blood flow or the blood supply to something, right? So myocardial perfusion is the blood supply that comes through the coronary arteries and then perfuses into the heart muscle itself. So that's what we're imaging this time. Before we got an ejection fraction, like was mentioned. We did that by filling a chamber and then seeing how much radiation was in that chamber, or how many counts were in that chamber, and then how many counts went out of that chamber. In this case, we're filling up the muscle and we're looking at where in that cardiac tissue are you getting blood flow. And when we do a stress test, we're looking at the difference between what does the blood flow to the myocardium look like at rest, and what does it look like at stress, and are there defects? And so we'll get into that more, but that's the main idea of what we're trying to look at today and what we're imaging. So thanks for participating, guys. All right, so if we want to look at perfusion, which is myocardial blood flow, we need to understand kind of the coronary arteries and how they function, their anatomy. So here's kind of your basic anatomy. And for our purposes as nuclear medicine techs, you don't need to know. You need to know the three main coronary arteries. The coronary arteries branch off to smaller things as they go out, but really knowing those three main are going to help you with what you're doing when you're imaging and what you're looking at and what we're trying to produce. So that I'm going to go over the three main. Now, as soon as I said that, I'm really going to kind of mention a fourth one, but we'll talk about that. So what you have, if you look over at this picture on the right, coming off the aorta, kind of more towards the lateral side, you're going to have the left main. So you have a main artery that comes off that, and then it branches into two separate ones. And so these are two of the three. So you're going to have your LAD. Your LAD kind of comes off anterior and then kind of drives septally towards the septal area, kind of underneath. Then you have your circumflex, which comes off kind of the top end, and it swings back to the lateral and then swings around posteriorly. And then you have your right coronary artery, which comes off the other side of the aorta, and it's going to swing down and kind of feed, and we'll talk more specifically, but it's going to swing down and feed the kind of septal area of the left ventricle and the right ventricle, okay? So here's like, this one's a little more detailed and this is a little more simplified to look at, but those are the three we want to discuss and talk about and think about. And then you'll notice on this one, this is like I was saying, they branch further, so you have like the right marginal branch and things like that. So things get more, but for us, I just want you to understand those three main, and at the left main, I guess we could say fourth, but really those three main are the ones we'll think about when we're looking at our imaging and producing stuff, okay? So I've listed out in the next few slides kind of the specific area where it feeds, and I tried to kind of separate this out. And one thing I want you to think about, everything we do in nuclear cardiology, when it comes to perfusion, we're really just focused on the left ventricle. We've talked about in other classes that the left ventricle is the main heart pump, right? It's what sends everything to the blood supply to the rest of the body. And so when we image, that's what we're going to image. We're going to image the left ventricle. We really don't do much with the right. There are times when we can see the right ventricle on our pictures and some things that doctors may sort of look at, but our main concern is the left ventricle. So when I tell you how these coronary arteries are perfusing these areas and I show you pictures, we're just thinking of that left ventricle, okay? Like I mentioned before, the right coronary artery provides that right side, but it's going to be a certain spot on the left ventricle. So with that in mind, what I've listed here then is the LAD, and I've highlighted kind of, there's your chamber, right? There's your the left ventricle. And so it supplies the branches in an anterior septal area. So it swings out towards the anterior and then goes towards the septum, kind of swings out to the right on their side, okay? Some people call this the widowmaker. When you hear people talk about the widowmaker, it's the LAD. The LAD feeds the biggest part of the left ventricle. So if you lose your LAD, your heart function goes way down, right? So that's kind of, people refer to that often as the widowmaker. There are some times that you will hear that left main, where before the LAD and the circ branch, you'll hear that called the widowmaker. There's debate. I've seen books call it both. I doubt you're going to be tested on that. You might, but LAD is considered the widowmaker. Okay, so for the circumflex, this is the one that kind of comes and goes lateral and then posterior, lateral and posterior. So it branches off for the left ventricle. And you can see I've tried to kind of show how that, you can see it right here kind of branching towards the back and the back of the heart, kind of getting everything posterior. And then also you can see that it comes off laterally on the heart. And then that last one is RCA. Again, its branches supply the right ventricle, the inferior and posterior walls of the left ventricle. So again, not really concerned with that right ventricle. When we think RCA, we're thinking inferior, posterior, inferior walls of the left ventricle. So here's just kind of, again, another view with those same type of things listed, where you can kind of see the areas, if you were to look at the entire heart, general areas that it's feeding. So just more to include for you to understand that. But again, as we start to look at the pictures we produce, you need to have this concept in your mind of where these arteries are located, and then what areas of the heart are we supplying blood to. And also, guys, just a reminder, as always, if you have questions, just interrupt me. That's the best way to do it. Okay, so we need to talk about the heart is unique. So you guys are used to, a lot of you have like x-ray backgrounds and things like that, and you're used to the normal anatomical planes that you work with in the body, right? So you're used to like sagittal, coronal, and axial, and how those break up the body. So the heart is a little different. The heart gets its own anatomical planes, and the reason is because it sits kind of funny in the chest itself, right? So I want you to think about the left ventricle being like a cup, okay? So that left ventricle is a cup. The way that it sits in the heart and the way the heart is positioned is the heart, if we were to look at the anterior wall of the heart, it's actually not anterior straight towards the body. It's actually slightly tilted, almost at like a 45 to the left side of the body. So that anterior part of the heart is actually tilted a little. And then the other way that the heart changes is when we're going to talk about the base of the heart, which would be the top of the cup, the part you drink out of. And then apex, which is the bottom of the cup, right? So that's the apex of your heart. So if we had that cup and we already tilted it slightly 45, then the other thing is the base or the top of the cup is tilted towards posterior side of your body, and the apex is tilted anteriorly. So that's the way the heart sits in the chest. So because of that, and because when we image, we look specifically at the left ventricle, the cardiac anatomical, it has its own planes, and that's what we're going to talk about right now. So understand and kind of look at this after we go over it, of course, and you're going to have similar things to coronal, sagittal, and axial, but they're just slightly different. And getting that in your head will help you as you look at images as well. Okay, so this is a really good picture. So this picture has this same heart exactly like it would be in the body, but then showing you the planes and how they're changed, right? So let's kind of talk about this. So you have what's called the short axis, okay? And your short axis would be much like your axial. So this cuts or makes slices of the heart from apex to base. You can see that line coming through. So this would be very similar to what you guys are used to looking at the axial plane on a CT. Then you've got the horizontal long axis, which cuts slices from anterior to posterior. So again, the anterior portion of the heart being slightly tilted this way, right? Slightly tilted to the lateral side. So this one would be comparable to like your coronal slices, right? So you're from anterior to posterior. And then the other one you have is the vertical long axis. This would be like your sagittal plane that you're used to. This is separating. In this case, I'm not going to say I'm going to say from septal to lateral wall. Okay, so because we're thinking about the left ventricle, so that's going to come from septum to lateral wall. Okay, so that's your posterior, that's your planes. Now, when we view these images for stress testing, we're going to view these as slices, just like you would on a CT. Okay, so we need to talk about how that translates into what a slice looks like when you look at it, and how we look at those on an image. So, like I mentioned, the short axis is slices from the apex all the way to the base. So if you do that for a ventricle, right? So your ventricle's like a cup. You're going to end up with something that looks like a donut. If I took my hand like this, if you can see me, make sure I'm viewable, but if my heart was here like this, and I took it out of the body and then put it like this on the screen and sliced it, that's what you're going to end up with, a bunch of donuts, right? And so what they have here is they've tried to keep these anatomically making sense, just like you would look at any other image like a CT, okay? So when you look at an axial in a CT or an X-ray or anything else, you're going to notice that the anterior is always faced up, inferior is down to the bottom of your image. In this case, septal is going to be on our left, and then lateral on our right, because we're looking from the apex coming up through to the base, okay? So when you look at that donut shape, this is your lateral wall, your septal wall, your inferior wall, and your anterior wall, okay? Now, for the next one, which is the horizontal long axis, again, this is like a coronal slice, right? So it's from posterior to inferior. So what they've done here is, again, they always want to keep, if you have a septal part of your image, it's always going to want to be towards that right side of the patient. And if you have a lateral part of your image, it's always going to want to be to that left side of the patient. So on this case, it's like taking that cup out of the chest. And if we go from this view, we're just simply flipping it down. So from our donut shape, we're just taking that cup and we're flipping it down. Okay. And so again, you have your septal wall, you have your apex, and you have your lateral wall. Okay. And then the last one is the vertical long axis. Again, this is much like cutting a sagittal view through the heart. So we're going to go from, or excuse me, I said that. No, I didn't say that wrong. Sagittal views through the heart. So we're going to end up with slices. And with this one, again, when you get a picture, they're going to try to keep anterior, anterior, inferior, inferior, and then with what you're left. So this one is like if I took that first donut, right? We put that donut up, and then we just flipped it sideways, okay? So here's the anterior part of our donut if we have a circle, and we're just flipping it this way. So anterior is still anterior, inferior is still inferior, and now our apex is over on the kind of the right side of the image there, okay? So this took me a minute when I was a student to get like, what in the heck am I looking at, okay? So look at this, study it out. When we look at images, that's what we're looking at. One thing that helped me is This one, because it's called the short axis, that reminds me of axial. So it's very similar for me to think about axial images. One of the things that helped me with the horizontal long axis is if you think of a horizon, you see a rainbow on the horizon. That's the way I started remembering it and trying to get it in. So when I do the horizontal long axis, I've got the rainbow, and then that way I can start remembering septal, lateral, and apical. And then, of course, the other one is the vertical long axis. So it kind of goes vertical along that plane. So anyway, whatever you can do to help you remember, but that's what you're going to look at. The reason why this is kind of important is because as you start to identify areas that are missing blood flow, this is how doctors on reports and how the communication goes in nuclear cardiology. When we start identifying those areas, we're going to say anterior, septal, lateral. You're going to be using those, and you need to understand when you look at images what you're looking at and be able to identify it. All right, so we're going to talk about radiopharmaceuticals. We'll get into stress protocols. We'll get into the stress medications we use, and finally get to stress testing, and then on to looking at some images. So we're going to get into radiopharmaceuticals. For this discussion, because we're not covering PET, I'm just going to go over three different types of radiopharmaceuticals. These are the most common. We're going to do thallium-201, technetium sestamibi-based, which is called Cardiolite, and then a technetium-99, which is called tetrophosmin, or MyoView is the one the brand name that people call it. So the reason I'm covering these three, technetium is the most likely thing used in your regular nuke med department if you don't have PET. Thallium you may see, especially if we get shortages on technetium. You can see thallium come back into play. Also thallium for a lot of facilities that don't do PET, when you do a viability scan, which we'll cover next time, you'll use thallium for that. And we'll talk about why that would be today. The other reason thallium's on there, thallium is old. Most people don't use it anymore. However, it is still on the boards, and it helps. Thallium was kind of the original guy, right? It's the original OG radioactive tracer for cardiology. And so the way thallium works, which we'll get into, kind of is what helped define some of the terms that are used in nuclear cardiology. And when we go back to looking at technetium, those terms don't always apply. And so I'll try to clear some of that mud for you, so it helps you to start with a base of thallium to kind of get where everything was built on and where it goes from there. And that'll make a little more sense here in a minute. Okay, so let's talk about thallium, right? So thallium is produced in a cyclotron. It decays by electron capture with an energy range of 69 to 81 keV. Anybody remember what electron capture is? Who wants to be brave? I'm throwing that out there because these are kind of things you need to remember. Definitely need to know what electron capture is for your test. Even if you think you're wrong, you're like, just be brave. No one's going to judge. No
When
one's
the orbital electron is taken in by a lower level orbital, and it has to give off energy so that it can live in that orbit.
Yeah, so you're very close. You're right that it's taking out a K shell electron. So what you have is you have a protein. You have a proton-rich nucleus, right? And being proton-rich, it needs to bring in a negative charge to even things out. So in this case, it reaches up and grabs that K shell and brings it in. And then yes, you're right. So at that point, what happens is you start to get a bunch of characteristic X-rays as everything fills in the shells. So good job. You're right on the right path. That's exactly what happens. So with this, we actually have a lot of the emissions are characteristic X-rays, 88%. And then you have some gamma rays in this upper range, about 12%. So this is one of the unique situations where in nuclear medicine, what we mainly are using here is actually characteristic X-rays to get our images, not the gamma rays. And the reason being is there's just not enough gamma rays that come off of this. It's mostly characteristic X-rays, okay? Now, what that means is that you'll notice this energy range isn't great. So you use low energy collimators on these, but it's still in the super low range. And so we don't get great images with thallium. And this is the reason why, is because we're imaging X-ray, and it has a hard time with the collimators. It just does, you don't get as good a resolution. It's a little more of a struggle because they're not gamma rays being used. You could set a window in your camera to still look at this range and pick up the gamma rays, but because it's only 12%, you're just not going to get enough on your image to really help you out, right? So this is kind of one of the downfalls of thallium. And you'll see as we keep talking about it, there was good things that it did for stress testing later on, which is why they used this for so long. But interesting to kind of see that we actually image characteristic x-rays with this. So this is a 73-hour half-life. So we don't love that for patient dose, right? Really long half-life. They're getting those low x-rays for quite a bit of time. So this exposure is not great with this. This is a potassium analog, which means it's just similar to potassium in chemical structure. And so the way that it works is it works by active transport with the sodium-potassium pumps in your muscle, right? So that's how it gets into the cell. And so again, it acts like potassium, and that's how it works. So when you inject this and it circulates through the system, the distribution that gets in the myocardium is very rapid. It happens quickly. And this is an important phrase, which is why I highlighted it. It's proportional to blood flow, okay? If you think about what we're doing in perfusion stress testing, we're trying to see and calculate and quantify blood flow in the heart muscle, right? So it's important. The only thing we get counts off of is however much of our radioactive tracer goes in, how much thallium or technetium or whatever we're using. The nuclide is what gives it off, right? That's what tells us how much. So the idea that it's proportional to the amount of blood flow becomes really important. That's the way we can actually measure these things and look at them. It has about an 85 to 90% extraction efficiency, which just means that when it goes into the system, 85 to 90% of it actually gets into the myocardium, and that's what we use for imaging. So you're going to have some that distributes around the rest of the body, and that's what I put right here. The other distribution includes GI, skeletal, things like that. So it's really good at getting in there fast. Even though that's the case, you still only have about 3 to 5% of the dose that's localized in the heart. So it's not a lot. It's just very efficient at getting in there for the amount that does. That seems sort of confusing, I know. Don't stress about that too much. Just understand that you're also going to have distribution in your GI, skeletal, kidneys, some in muscle because of the sodium potassium pumps. But that's how it works. Now, this is the interesting thing. Thallium is a very interesting nuclide because it has a principle called redistribution. This is going to become even important again when we talk about later scans on our next lecture. Is talking about this idea of redistribution. But what that means is thallium, as soon as you inject it, it goes immediately into the heart very quickly and very efficiently. And it stays there for about 10 or 15 minutes, and then it actually washes out. So it goes back into the vasculature, and it can actually circulate around again and be uptaken by the heart again. We call that redistribution. So it's kind of a unique way that thallium works, and we really don't have any other nuclide that does that. That goes into the heart, stays for 10 or 15 minutes, and then goes out and can be used again. But that's what thallium does. Most of the excretion comes through urinary clearance. Biological half-life is 55 hours. So again, that's what kills us on the dose. It ends up being about 20 millisieverts because of that long half-life. So not great in terms of patient exposure. Usually you use somewhere between 3 and 4 millicuries of thallium on this. So again, just remember with this, it's kind of that unique characteristic that we image, but not great images because we're using characteristic x-rays. And then remember that idea that it redistributes. That'll become important when we talk about how a thallium protocol works. Okay, next one is sestimibie or cardiolite. So this is, this is technetium. So in terms of the nuclide itself, you guys are probably well familiar with this by now, but produced in a molybdenum generator, just like all other tech products, decays by gamma emission. So now we're using gamma. We're not using any kind of characteristic x-rays anymore, and that's good because that means we've got an energy range of 140 keV. So our collimators like it better. We can produce pretty good images out of that. As you guys know by now, 6-hour half-life, right, from doing all your math. This is extracted into the myocardium by binding to cytoplasmic mitochondria. So it's the mitochondria that brings it in. It takes it in, that mitochondria eats it up. Distribution, again, is proportional to blood flow. We have to have that when we look at cardiac nuclides because we have to have it match the blood flow. This one has about a 60% first pass efficiency, so it's a little less efficient at getting into the heart muscle than thallium, but it's still pretty decent. This does not redistribute. That'll also become important when we talk about why we do the protocols we do with Sestamibi with Cardiolite, is that once it goes in there, it's in there and it's going to stay, and it's going to stay where you had it at the moment that you put it in. And again, you've got 6 hours, right? A 6-hour half-life. So that's going to make a difference on what you can and can't do.
I have a question.
Yeah, go for it.
Is extraction efficiency the same thing as first pass efficiency?
Yes, they really are the same. The first pass efficiency just means that it's very quick. Like the extraction that gets in there happens. So they are slightly different. But the first pass it means when you inject it, it's the first time through the cardiac system. So they're different in that sense. And this one happens fast. And then the other one is just how well does it do? Not on one pass, but on as it circulates through the system, how well does it get into the tissue?
Okay, that makes sense. Thank you.
So again, doesn't redistribute. Normal distribution is going to be similar to some of the free tech stuff you're seeing and some of the Sestamibi stuff you're used to seeing from using it on things like parathyroid and things like that. So as you can expect, obviously we want to see it in the myocardium. You may see this liver, GI, thyroid, and parathyroid, okay? Hepatobiliary clearance can take 45 to 90 minutes. So when we talk about a protocol and certain things that we do during protocols and certain things we run into with gut uptake, we'll get into it more. But remember that this can be something we have to keep in mind when we're doing our protocols, is it can take it's uptake in that heart, but it can be uptake in that hepatobiliary GI area, and it can take 45 to 90 minutes to clear. So that'll become important later. Delayed imaging is possible because, again, with this particular isotope, it's going to go in and it's going to stay in. You got 6 hours. It's going to be where you went in, where you initially injected, and it's going to stay in at the state that the patient was in at that moment. Excretion is primarily biliary and renal. That kind of gives some percentages. Biological half-life is 3 hours. So you remember on our last one, your biological half-life was 55 hours on thallium. This is 3. So this is awesome. So this one, that biological half-life, comes down to about half of what the regular half-life of tech is. And so it because of that renal excretion, it gets it out a lot faster. This brings your average patient dose down to about 10 millisieverts. Okay, so this is much better in terms of patient dose. So you can already see, just in looking at these two and comparing them, why you would start to go towards a tech-based product, because your dose goes down, your image quality goes up because we're using a higher energy. And then there's other things that we'll talk about as we go along with protocols, but it's just a much more efficient, much better use of a nuclide. So then the other one is very similar. There's not a whole lot of difference. It's just MyoView is just another brand. You'll notice that most of these are the same. That first pass efficiency goes down a little bit. There's also been studies showing that using MyoView, it underestimates myocardial blood flow at high flow rates. So when we do stress, we have high flow rates, so that it can be underestimated. Hepatobiliary clearance, actually, they show us a little better with MyoView. So you're looking at 30 minutes instead of 45 to 90. Pretty much everything else is the same. I've never used MyoView. I don't know if any of you use MyoView at your facilities. Any of you use MyoView? I don't see it used a lot. Most of what I've seen, Cardiolite's kind of the standard. Anybody?
We use MyoView for the most part. Yes, and I don't really know the main reason, but the techs seem to like it because they say that system maybe sticks too much to the syringe, and that we can lose plenty of millicuries in the process.
Oh, okay.
They prefer it.
Okay, that's a new one. I didn't know that. And a lot of times too, and that may be a preference thing. I don't know. I think a lot of it too comes down to your pharmacy that you use, and depending on where you live and your facility and the pharmacy they have contracted, certain pharmacies will use certain things. But most of the time when I ask that question, I do still get a few areas that use MyoView, but I think most of them use Cardiolite. But again, they'll both work. They just have some slight differences here and there. But that's a new one. Thanks for sharing that. I didn't know that that's some good information that it may stick to the syringe a little better. Maybe you have to flush it a few more times. So yeah, thank you. All right. Okay, so that's kind of your three. Those are the three that we'll kind of reference today. Before we get in now to talking about protocols and how we do stress, we need to identify why we do a stress test in the first place, and a couple of different things that we'll see when we look at images. So I want to ask this question that kind of helps us set the stage. But what's the difference between ischemia and infarct?
Ischemia is lack of blood flow, and infarct is death of muscle.
Yeah, you're exactly right. Thank you. Who was that?
It was me.
Okay, thanks. Yeah, that's exactly right. So ischemia is a reduction in blood flow, and then that infarct is an occlusion of blood flow. And this part's important, resulting in dead tissue from lack of perfusion. So usually when we have an infarct, we're saying that tissue's gone, it's dead, it doesn't receive blood flow. Infarct can also just mean that there's an occlusion, an emergent occlusion of something that's not getting blood flow. When we look at images, I want you to think more in terms of that tissue is not functioning. It's gone from lack of perfusion. Okay. There's a couple other things I mentioned right here that are going to be important. This idea of what's called hibernating myocardium. So you can get, and usually this happens with repeated ischemia over time. Patients that have heart disease and they've repeatedly had ischemia, you can get myocardium that's hypovascular. So it's really, really low in its blood supply. And what will happen is instead of it just being dead tissue, it will still be lightly perfused. So it's tissue that's alive, but it's lost its kinetic wall motion. So the functionality of it is reduced and gone. And so it can appear to be infarcted, but it's really they call it hibernating myocardium. And we have a test that we'll talk about on our next one, where the question is, can we prove in some way that tissue is still alive? And if that's the case, can it be revascularized? So hibernating myocardium is another one. Again, we won't really cover that much today. We will next time, but keep that idea as one of the things that can also be happening. You can have ischemia, you can have infarct, which is total loss of blood supply, but there is this caveat of hibernating myocardium. And when we talk about viability scans, that's what we're trying to identify in a viability scan. And then the last thing I put on here is stenosis. Just understand that stenosis is an abnormal narrowing in a blood vessel. Now, I should probably add one more term on here, and that's arthrosclerosis. The difference here is that stenosis is just any kind of narrowing. That it can be from anything, a tumor of anything. Stenosis can be just a narrowing of a vessel, right? Whereas arthrosclerosis is specifically because of coronary artery disease, calcium, and plaque. So that's something to keep in mind as you're hearing terms as well. So I kind of put these pictures in here. So, if you have normal blood flow through coronary arteries, you see this. Ischemia is somehow your blood supply has been reduced. We'll give more caveat to that, to ischemia, as we go along. And then, of course, infarct is there's complete occlusion and there's no blood supply getting through. Okay. The other thing I want to kind of bring to you, and we talked a little bit about this when we did our EKG stuff, but just to keep in mind again, when we think about EKG, we identified EKG that when we look at the ST segment, right, which is the segment here, when your QRS complex ends and your T wave begins, when we have a reduction in that ST segment, that's indicative of ischemia. So again, we're thinking reduced blood flow. And when we have infarct, when we see an infarct, we see an elevated ST section, right? And so those are kind of the two that can be identified on an EKG. All right, now let's get into talking about how we stress our patients. So I want to ask this question. When we do a stress test, what are we actually trying to achieve by either running them on a treadmill or giving them some kind of stress medication? What are we after? What are we trying to do with the body? What's happening?
You want to open up the vascularity of the heart?
Yeah, that's exactly right. We're trying to dilate blood vessels, right? A lot of times we'll get patients come in and even techs when they're learning will say, oh, we're trying to increase the heart rate. Are we trying to get them to exercise a certain amount of minutes? All of the things that we do, however we stress, essentially what we're trying to do is get vasodilation, okay? So in the case of exercise, when the body works hard, the heart and all of those muscles that are working hard, they need increased blood flow to them for oxygenation, right? For hardworking muscles. So to accommodate that, the body needs to vasodilate. It needs to increase blood flow to the muscles of the heart. Same thing, or excuse me, to the muscles of the body when there's exercise happening. The heart, when it does that, it has to speed up. So it's having to work harder. You need vasodilation within the heart or within the coronary arteries for the heart to do its job, right? So, but it's important that you understand is what we're trying to do is vasodilate. That's what we're after, okay? So I also listed on here under stress conditions, myocardium supplied by the coronary arteries that are stenotic may become important. So one of the things to understand too, with coronary artery disease, with plaque and with calcium, with atherosclerosis, like I mentioned, when you start to get a buildup, like you see in these vessel walls down here, within the walls, understand that when plaque builds up, it builds up within the layers of the actual vessel. So I remember when I was younger and my dad had heart disease and he had a heart attack. And the doctor described like, oh, there's plaque in the arteries. I remember thinking, well, can't you guys just go in there and like roto-rooter it out and like shove it down the way? And that's not the case. It's not that something is building up inside the vessel itself. It's within the layers of the wall, right? So you can't go in and roto-rooter that out, which means that as that happens, the actual lumen of the vessel gets smaller and smaller as heart disease builds up. What happens in the case of vasodilatation is that when a healthy blood vessel, when you exercise in any kind of way, you're going to get that blood vessel responding and dilating. When you start to get that buildup of calcium and plaque, especially when it hardens in place, those vessels lose their ability to dilate. And that's really the question we're trying to ask when we exercise a patient, when we give them medication is, can those vessels dilate, right? So when we do our rest scan, we're going to have kind of a baseline of what the blood flow looks like. And then I'm going to try to dilate in some way. And what I'm looking for is I want to see every area of the heart dilate and increase in blood flow. If there are areas that do not increase in their blood flow, then they're ischemic. So this is important to understand as well, because when we say ischemia, we say reduction in blood flow. But what I want you to understand is when you exercise a patient, you're not reducing their blood flow in ischemic areas. What you're doing is you're increasing everything else. So in comparison to the areas that increased, that area that did not increase because it didn't dilate is reduced in blood flow compared to the areas around it, okay? So again, when you exercise a patient, you're not cutting off blood flow. You're just not able to increase. Does that make sense? That one was one I didn't understand when I was in your spot either. Okay, let's talk about patient preparation. So patient prep, patients need to be NPO. Waterstrom is going to tell you 2 to 4 hours. Most protocols that I've seen are somewhere between 4 to 6 hours. At our facility, we use 6 hours. If you think about most of your gastric emptyings that you do in your facilities, most of the time you look at a gastric emptying over a 4-hour period. Why do you do that? Well, because you're looking at how well is the stomach able to empty its contents, right? And we do that for 4 hours for a reason. So I would think that anything under 4 hours is probably not a protocol you'll see. Again, I listed Waterstrom's. 4 to 6 hours is the one that I've seen the most. One of the reasons, and we'll get into this as we look at images and things that can happen. The reason that we go NPO on these tests is because, again, we don't want bowel active. Remember when we talked about where distribution is, especially with technetium-based products, is you can get distribution within the GI, and you can get it within the liver, hepatobiliary distribution. So the problem that comes up in our images is the heart, where the heart sits and where the stomach sit are almost on top of each other. And so if we get perfusion into the stomach and we get that gut uptake is what we call it, and it's right below and on that base of that heart, it's going to sometimes interfere with being able to see the apex of the heart, right? And we don't want that. So the reason we don't eat is because we want the stomach to be not active at all. When you have your stomach actively trying to digest something, well, think about it. The stomach's a muscle, right? And we talked about how our tech products especially are attracted to that muscle through the mitochondria eating it in, right? So we want to have a stomach that is not active. So that's why we fast for a stress test. The next one is we want them to be off beta blockers. Beta blockers affect heart rate. So if we're doing an exercise stress test, especially, we don't want anything that's designed by nature to keep the heart rate down. Because if we're counting on the heart rate to be the thing that gets the body, we want the heart rate to go up, and that's what we use to say, okay, if I can get a certain heart rate, then I know that I'm vasodilated. All the normal processes in the body have led to vasodilation. If that's what we're relying on, then beta blockers might keep it so your patient can't get up to a certain heart rate. Okay, so we want to be off that. ACE inhibitors can affect blood pressure, and blood pressure can affect heart rate response. So that's the reason you don't want them on ACE inhibitors or calcium channel blockers. Oh, and I forgot to mention up here with the beta blockers, you'll see LOL at the end of their names. It's hard to know all of the beta blockers. Most of them have an LOL, like propranolol, carvedilol. You'll see the LOLs, that's your beta blockers. And then usually with your ACE inhibitors, it's like lisinopril, you'll see your ILs. Not all of them are that way, but a lot of them are. And so it's a good way, as a tech, if you're looking through a patient's medications, you can identify those. At the place where I work, we actually have on a sheet that we would attach to our clipboards, although it seems like lately I haven't seen them floating around, but we had a sheet at one point that just listed all the common medications so that as you're interviewing your patient to find out if they prepped right, you can look at some of those medications. But those, again, beta blockers, ACE inhibitors, calcium channel blockers, we want to have those off because they can affect heart rate. And then we don't want them on anything that's like a long-acting nitrate or vasodilator. Obviously, if they're on anything that's vasodilating already, well, then they're basically in a stress type state already. And no matter what we do, whether it's medication or exercise, we may or may not get an accurate dilation and an accurate comparison between a non-dilated vessel and a dilated vessel. So I want to keep them off that. And then the other one is caffeine for 24 hours. There are some protocols that say 12. I've seen both 12 and 24 hours on the caffeine. Caffeine binds to the same receptor site as many of the medications we use, the A2A receptors. It binds to adenosine. Adenosine, when we talk about the medications, adenosine is used in several, or an adenosine byproduct is used in several of those medications that we use for stress. And so we don't want anything that's already bound to those A2A receptors, which is caffeine, being in there. The other thing is that caffeine is a bigger molecule than most of the stress medications that we use that bind to the A2A receptors and cause the dilation to occur. And so what that means is that caffeine, if it's in there, even if you put your stress medication in, it's not going to let it in. I always compare it to, I've got two boys. My one son is 18, my other son's 13. As you can imagine, if the 18-year-old, my 13-year-old Tyler, he has a sweet room. Like, he's got his video game set up with all these cool lights. I mean, it's a pretty chill place to go into. And of course, my older son, Jared, likes to go in there a lot. And if Tyler doesn't want him in there, there's not a whole lot he can do about it. He'll just go in there anyway, right? So it's kind of the same way. Like, caffeine is like a big brother. If he's in there, your medicine's not working. Okay. So now we'll talk about those. That's what the prep. We'll talk about the types of stress that we can do. So the first one, and this is the most common thing used. There are other types of protocols, and you may have a few at your facility. I'm going to cover just what's called the Bruce protocol, which is kind of like the gold standard that's used. And there might be slight variations to some of these, but some of the principles are very similar. So for a Bruce protocol, you're going to do a full 12-lead EKG hookup. Okay. This may vary depending on your facility. At our facility, we do the 12-lead EKG hookup, and we run the treadmill test with one of our PAs or one of our doctors. That might change in your facility. You might have an EKG tech come, and all you're going to be responsible for is injecting the dose. and you'll have a PA directing the stress test. There's a variation of that that could happen, but either way, you'll have your patient will be hooked up to a full 12 lead EKG, so you can monitor the EKG and the waves and the things that are going on. So the Bruce protocol starts at a walk, and every 3 minutes you're going to get a little steeper and a little faster. Okay. Blood pressure is taken every 2 minutes and recorded, and we're going to inject the radiopharmaceutical at peak stress. So what is peak stress? So peak stress is defined as 85 to 90% of maximum heart rate. Well, what the heck is maximum heart rate? That's the next question, right? So max heart rate is determined by taking 220, and this stands for beats per minute. So 220 beats per minute, and then you subtract their age in years, okay? So if I were to do mine, I'm going to reveal my old age here. So if I were to do mine, I would go 220, and then I'm 47. So I'm going to subtract 47, and that's going to give me 173. Okay, so 173 would be my max heart rate. Now, how do you figure out when you need to inject? Because what's at peak stress, which is 85 to 90. So all you do is you would times that by 0.85. Whoops, sorry, I did that wrong. 0.05. I just lost my number. Hold on. 220. 7. Okay, so times it by 0.85, not 0.085, sorry. My calculator gave me a weird number and I thought, did I do it wrong? So I got 147. So my 85 to 90% would be 147. So if I was getting around on a treadmill, they're going to want to do every steeper, every 3 minutes, or every 2 minutes, gosh, I can't talk, you guys, sorry. Every 2 minutes, steeper and faster until I at least get to that heart rate of 140 something. Okay, so that's how you would do it. So at that peak exercise, that's when you would inject your radiopharmaceutical into the patient, and then we continue exercise for 1 to 2 minutes post-injection, so that we kind of maintain that vasodilation while the medicine goes in. It circulates through your system, and the cardiolite uptakes through the mitochondria or whatever nuclide you're using, and it gets in there. Now, one of the biggest reasons for a common false negative on a stress test can be inadequate stress. When I say inadequate stress, we don't get vasodilation or correct vasodilation, okay? So that's why the protocols are set up the way they are, because they've done tests to ensure that there's vasodilation. There's not a way you know when you're running a stress test that you're like, okay, well, I can see something that tells me the patient has vasodilated. But the studies and the literature that have been done say that if you use this 85 to 90% based on the 220 minus the age, and we inject at that peak stress and then go 1 to 2 minutes post-injection, that works and is efficient. So that's gonna be our stress test. And there's some caveats to this. And if you've been doing these already, there's things you have to think about and work. Like, for example, when we do an EKG hookup, this is one of the main reasons when we talked about our EKG hookup, why we don't do what a lot of EKG techs are, which is put their leads way out on the wrists and way down by the ankles, right? Because we can't be running a treadmill and having our patient go steeper and faster every 2 minutes with EKG wires all over the place. There's also, we have belts that people wear that will connect the EKG module to them. There's some management here, and it's probably depending on your equipment that you have to learn as a tech to manage how this is going to work out. The other thing is that the patient's going to be running on the treadmill. A lot of patients like to reach on and grab the front of the treadmill. That can't happen the whole time, because there's going to be times where whoever's taking the blood pressure, in our case it's a PA, it may be your doctor, they're needing to borrow that arm to take the blood pressure. You're on the other side getting ready to inject radiopharmaceutical. And so there's things, this is a good one to get into a facility where you can get experience at running an exercise stress test and get used to how you're doing that. I've had situations where people have spilled their pharmaceutical, their radiopharmaceutical all over the place because something happened when they were running and someone moved. And so the other thing that I would say is very important with this is communicating with your patient this process. You don't have to obviously tell them, we're going to figure out your max heart rate and this is how you figure it out, but letting them know before the stress test, every 2 minutes, going to be steeper and faster. We're going to be taking the blood pressure. At one point, I'm going to still your arm to give you this injection, and I need you to hold it still, all those kinds of things. Also, just managing your patient and the way they're feeling, and whoever's paying attention to the EKG needs to pay attention to that EKG so they know if there's any abnormal things happening with EKG waves, all that kind of stuff. So just this is one that definitely get experience if you can get there, if you've got if you do cardiac or if there's a facility you can get to, because there's a lot of caveats about actually doing this as opposed to just learning it. So contraindications to a Bruce protocol are what we need to talk about. And we mentioned this already when we did some of our EKG, but a left bundle branch block. Again, I talked to you guys about how the waveform of elevated ST segment, which is a STEMI, can look a lot like a left bundle, right? So this is a left bundle branch block here on this, and they look very similar to what a myocardial infarct will look like. And so, and you can imagine too, as you put someone on a treadmill when they have a left bundle branch block, and then you increase the heart rate, it gets to where it's very difficult to see what these waves even look like besides just up, down, up, down, up, down, up, down. Okay. The other real main reason we do it is we get a false septal wall defect. So I talked to you about how, remember, when the left bundle branch block that comes down through that septum and it causes the contraction of the ventricle, a left bundle branch block means that from the AV node down that branch, there's some kind of slowing, right? There's some kind of slowing that's not communicating. And so that left bundle branch block, you're going to have, if you get the heart rate going really quick, blood flow has to fill in between contractions in the myocardium, right? When it's contracted, it's harder for blood flow to get into the coronary arteries than when it's relaxed. So when you're exercising, you're getting fast heart rate. That's a lot of contraction happening. And if that rhythm is not happening in a timely manner, it's hard for blood flow to fill up. And so you can get a septal wall defect, meaning that you get less blood flow in that septal wall during high exercise on someone that has a left bundle branch block. So when you put your images up, you're going to look at that septal wall and you're going to be like, oh my gosh, they've got a blockage in the septal wall. Well, no, you'll go up to the cath lab and it's not a blockage. They'll find out there's blood flow there. It's just that because of that bundle branch block and that high exercise, it couldn't fill in. The other one is in contraindications, just exercise tolerance. Some patients, whether they have orthopedic issues or whatever, they can't exercise. They can't get up to their max heart rate, and so it just doesn't work. Of course, patients that have to stay on a beta blocker, we've talked about why that is, because it affects heart rate. Active severe chest pain. If your patient comes in like, oh my gosh, I'm really not feeling good. Obviously, you don't want to get them on a treadmill. We need to have them looked at by a provider at that point. Extreme hypertension. Blood pressure typically goes up with exercise. And so if they're a very, very hypertensive patient, that's something that you need to, not be doing a stress test if they're really high, like in the 200s. The other one is if they're tachycardic and they have a naturally very, very high heart rate, like 140 plus, the likelihood is that your coronary arteries are already vasodilated because your heart is already having to work really hard. And so it can give you a false test where dilation, you're going to get a resting scan that's dilated, a stress scan that's dilated, and you're not going to be able to compare those two and make it any kind of assumption or difference. Okay, so those are kind of your contraindications to a Bruce protocol. Okay, let's talk about our stress agents, and maybe what we'll do. Let's see, we're at 1:30. Why don't we do just like let's see, let's just do like a 3-minute break, just a quick chance to get a quick break, and then we'll come back and then we'll finish out the rest of it. Is that okay with you guys? Quick bathroom break.
Okay, thank you.
Yep. We'll give it one more minute here, just make sure everybody gets back. All right, hopefully everybody's back. I'm gonna go ahead and get started. Just a quick break this time, since we have a lot left to still cover. Okay, so we talked about exercise stress and kind of how that works and what we're after there. Now we're going to talk about our pharmacological stress. I'm going to include 4 agents. There are other stress agents out there, but these are the common ones that you're likely to see. And even some of these you just may not see anymore. There's really one of these that's the most common, but we're going to cover adenosine, dobutamine, dipridamol, and then also regadenoson or Lexiscan, which is probably the one you're going to see most common nowadays. Okay, so adenosine, the way it works is it binds to those A2A receptors within the cell wall. When that binding happens, it inhibits the calcium entry and it opens up the potassium channels. That causes the walls to actually relax or dilate, right? So that's how you get that dilation, is those vessel walls relax out. Adenosine and caffeine obviously should be withheld for 12 to 24 hours prior to your exam. Again, I mentioned the reason for caffeine. Caffeine it goes to the A2A receptors as well, is a bigger molecule than adenosine. If adenosine is in there already and you put caffeine, it would kick it out. And caffeine's in there and adenosine comes in, adenosine will not bind, the caffeine will stay. So we have to keep that off. And then obviously, if your patient is on adenosine for some other reason, then they're probably already in a state of dilation. So you don't want to have them have that as well. So the dose on this is 0.14 milligrams per kilogram per minute for 6 minutes. So typically you have this on a little pump. You'll mix this up in a syringe. And however, depending on how your pump works and the size of your pump, you'll put enough saline in with this that it will give you that dose rate. Radiopharmaceutical is injected at 3 minutes. So again, the adenosine works for a few minutes, inject in the middle, and then you finish out. Side effects that you see in patients with this are headache, dizziness, flushing. They can have shortness of breath. They can have some chest pain. Obviously, that's something that's monitored. You can have AV block that occurs. And the side effects happen in about 75% of the patient. Now, when I say those side effects, I should add the caveat that chest pain and AV block are not part of that 75% that get them, right? It's the headache, the dizziness, the flushing, the shortness of breath. Patients are going to get that. And with this one taking 6 minutes to inject, they usually start feeling those effects pretty quick. And then it lasts for pretty much until you stop giving it. It kind of keeps it going. So it's kind of 6 minutes of not feeling great for your patient. So adenosine is not the funnest thing. It's not the best one to use. There's other ones that are better in terms of how it makes your patient feel. You'll notice here I listed that the biologic half-life is less than 10 seconds. So that 10 seconds is the easiest way to reverse this. If your patient is having an issue and suddenly they get chest pain or anything like that, we can reverse it by simply stopping the injection, right? If your patient goes into an issue, EKG suddenly shows there's ST elevation or something's going on, it's easy. Just turn it off. It will resolve on its own. Okay, so that's adenosine. Dipridamol is the next one. So the way dipridamol works is that it's an adenosine deaminase inhibitor. All that means is that it breaks down the metabolism of adenosine within the body. So what that means is that adenosine is naturally in the body for the same reason of vasodilation and things that occur in your body. But what happens essentially, it just breaks down the ability for adenosine to be metabolized, and it keeps it and it builds it up in your system. So dipridamol works in a very similar way in terms of getting vasodilation to the A2A receptors by adenosine. It's just that we're not giving adenosine. We're creating a buildup of adenosine within the body, within the system, okay? And so that's how we get our vasodilation. As you can imagine, the same thing, because we're relying on adenosine in the end, We want to withhold caffeine. Aminophylline is another one that can bind to the A2A receptors, very similar to caffeine. So if your patient's on aminophylline, that would be another one you want to keep them off. And I probably should list that on the adenosine one as well. But those should be withheld 12 to 24 hours prior to exam. The way this one works is you do 0.5 milligrams per kilogram in 20 to 40 ml of saline. They do a rate of 0.14 milligrams per kilogram per minute, and you go for about 4 minutes. Now, the radiopharmaceutical is injected at the end of that 4 minutes, or I have listed, the book says 3 to 4 minutes. As you can imagine, the reason for this is that, again, as soon as you start giving them the medication, they're not dilated right then, right? So we don't want to give the radiopharmaceutical before the dilation happens. We want to give it after dilation happens. And because it takes time for that medication to build up the adenosine, or the natural adenosine to build up in the system, that's why we inject at pretty much the end of the infusion rather than sometime during the infusion. So side effects, again, very similar. We see a little less side effect profile in terms of percentage in the patients on this one, but very similar to what you notice with adenosine, because again, this is just, we're using adenosine, we're just using the body's buildup of adenosine, okay? It can be reversed with aminophylline, so that's why I listed aminophylline on this one. So some of your facilities may keep aminophylline, or maybe a PA that has access to that. But aminophylline will go in and it's a bigger molecule that will go and bind to the A2A, and it will actually kick adenosine out of the A2A receptor, right? So it's a very good reversal for that to get adenosine out. You can use it in any adenosine situation. Okay, next one is dobutamine. So this is I have a lot of patients that they will ask when I'm giving them stress medication. They'll say, so is this the stuff that just makes my heart rate race, right? And as you can tell, like, for both diprinamol and for adenosine, they'll probably get increased heart rate, right? Because you get that vasodilation. When you dilate, blood pressure goes down. The body responds by increasing the heart rate and getting blood flow to that low blood pressure. And so it's a funny way to have to answer your patients, because yes, we increase heart rate with most of these. However, dobutamine is the one that actually acts on heart rate. Okay, so it's a beta antagonist. So it does the opposite of a lot of your beta blocker medication. Beta blocker medication will keep the heart rate down. This one increases myocardial oxygen demand, and that demand increases the heart rate to try to get that oxygen demand up by increasing blood flow, okay? So that's why it'll dilate those coronary arteries to meet that oxygen demand. So it's affecting heart rate directly. Again, like I mentioned, opposite of beta blockers, so we don't want a patient on beta blockers, and beta blockers need to be off for 48 hours. If your patient's on beta blockers, then dobutamine isn't going to work on them. So beta blockers are one you need to think about with dobutamine, and then also with exercise stress testing. So the way this one works is it begins with 5 to 10 micrograms per kilogram per minute for 3 minutes. And then we increase the dose every 3 minutes to a maximum of 40 mics per kilogram per minute. The radiopharmaceutical is injected 1 minute after the highest tolerated dose, and then maintained for 2 minutes while the radiopharmaceutical localizes. So to say that a better way, you're basically, people don't like this one. In terms of side effects, this is probably the worst for side effects. This is the one that makes people feel crappy the most. And I mentioned some of those side effects down here: tachycardia, palpitation, headache, dizziness, flushing, shortness of breath. More serious, again, ones can be VTAC and AFib, but patients don't like dobutamine. Most patients feel pretty crappy on dobutamine. And the whole idea of dobutamine is we're going to give that dose and we're going to increase it until the highest tolerated that they can, up to that 40 mics per kilogram per minute. And so you're kind of talking to your patient and working through with them, and how do you feel, and can we give you more? We're going to go a little more. And you're trying to just give them as much as you can without them just totally wanting to die. So this one is not a popular one to use. And you probably won't see it in nuclear medicine a lot currently. There may be some of your facilities that still use it. It's used a lot in some other stress testing that's not in nuclear medicine, and we've used it still for stress tests before, but it's not seen quite as much. You can see the side effect profile in terms of percentage here. Biologic half-life is about 2 minutes. It can be reversed with a rapid acting beta blocker. So that would be a beta blocker that's injected through the IV. Again, because they kind of have the opposite effect on each other. And then this one, people with severe asthma or COPD, it can be a contraindication to try to stay away from. I have seen physicians or PAs that will still do it in warranted situations, but most of the time, asthma and COPD, it can really exacerbate asthma and COPD. So that's dobutamine. And then we'll get to the one that you've probably all used at this point if you've done any stress testing, and that's regadenoson. You'll notice that it's an adenosine analog. It's regadenoson. Everybody calls it Lexiscan because that's the main name brand. For years, Lexiscan was the only thing available. Now generics have come out in about the last, I think, year or 2 years. There's generic versions, and so you'll probably hear it just called regadenosine because of the generics, but the Lexiscan brand kind of holds on. This is the one, again, like I said, most often used. So this is similar to adenosine in that it binds to the A2A receptors and has the same exact reaction of the vasodilation. Again, much like with adenosine, we don't want to be on caffeine. One that gets our patients a lot is chocolate. People don't think about caffeine being in chocolate, but it's in there and it can affect the stress test. It can affect the regadenoson and the A2A receptor sites. So 12 to 24 hours on that. At our facility, we go 24 hours for our patients, but some facilities I've seen do the 12. It's debatable with different studies. So this one is nice because this is the only one that we don't have to do over a certain amount of time in typical minute times and use a pump and all these other things. This one is nice. It comes in a bolus injection. It's 0.4 milligrams. You do a 10 to 15 second flush into the patient. So it's really easy, followed by 5 ml of saline. So this one you get to just inject it for about 10 or 15 seconds, follow it with saline, and it's in and it's done. It's a done deal. So it's kind of nice that way. Radiopharmaceuticals should be injected about 10 to 20 seconds after saline flush. If there are some debate about this that's come later, this is kind of the standard of what it initially was. We actually in our facility are waiting actually about 90 seconds. If you look in the packaging of Lexiscan, it will tell you that its most peak efficiency is at 90 seconds, but it becomes effective very quickly. Patients will feel it within about 10 to 15 seconds. They'll start getting reactions and symptoms. So that 10 to 20 seconds, I would probably put that up to 90. You probably won't get that kind of a question on your boards like about Lexiscan, but just for you as a technologist, depending on where you work, you may see areas where they inject it within 10 to 20 seconds, and you may start seeing things go out a little longer to kind of ensure peak effectiveness on the dilation. Side effects very similar to adenosine, although I will say that they seem to be less severe. One of the benefits of going to Lexiscan that everybody loved is it seemed to not affect their patients quite as bad. Now, I'll give a caveat with that because I have some patients that I'll give them Lexiscan and they're like, oh, I felt my heart a little bit, but no big deal. And then I have other patients that feel like garbage, huge headache. I've had patients throw up, and especially when you're doing that on a PET scanner. When you do it with a stress or with a SPECT scanner, you're going to have them off of the scanner and you're doing this and they can throw up in a barf bag. When you're doing it on PET, which we'll talk about later, you're giving them this and you're starting images right after. So they're imaging while they're feeling all this. And so helping a patient throw up is something I've done a few times. In fact, I don't know what I was thinking or what was going on. It must have just been the rush of it all. And I still get teased to this day about it. But I actually had a patient that was about to throw up, and I went to grab a barf bag out of the thing and they were gone. Someone hadn't restocked them. And so I hadn't even had a chance to get gloves on. And I don't know why. I don't know if it's a dad thing in me or what, but I ran over to the patient. They were about to go and I didn't want to go all over the scanner. And so I literally put my hands out and I caught her throw up. Not, not my finest moment, not something I want to repeat, but yeah. So you can get patients that have that severe of a reaction. But I would say the majority of patients, this is pretty mild. They feel it for about 2 or 3 minutes and then it backs off and it goes away. So it's pretty quick. And you'll notice that side effect percentage profile here down to 30%. That's accurate, like a lot less side effects with Lexiscan. So it's awesome. it's really one of the best ones to use because it's easy to give, less side effects. This one can be reversed with aminophylline or caffeine. It's usually a pretty standard practice in most places that I worked after a stress test to give, when you're using Lexiscan, to give the patient some caffeine to drink because it goes in. Again, anything that's left or bound into those A2A receptors is going to be kicked out by that caffeine. Plus, they've been fasting, so it gives them something to drink. Most patients really love it. They'll tell me like, "That's the best coffee I've ever had," or "That's the best Coke I've ever had," and probably because they've been fasting and it just helps them feel better. So it's kind of nice. Contraindications on this one, according to the packaging with Lexiscan, is they can't be in second or third degree AV block. So remember, first degree AV block is just where there's a long PR interval. That one's okay. But when we start to get to second or third, what we're getting is a breakup between the AV node, or excuse me, between the SA node and the AV node. And when those two aren't communicating correctly, Lexiscan can kind of exacerbate those disconnects and cause pretty bad heart rhythm issues. And so if that's an important thing as you're, again, whether you are the one responsible for your EKG or whether each EKG tech is, it's still something for you to be aware of as a tech because you're the one giving the Lexiscan. So if they have, if you don't do it, you might even ask the tech or the EKG tech, like, "Hey, how does that look? No blocks, right?" And just verify that because I could see getting an EKG tech that wasn't up to speed or wasn't aware, and you don't want to be in that situation. So I would always check second or third degree AV blocks. We do not want to give them Lexiscan. I put this down here as relative contraindications. I'm listing seizure history. So in the Lexiscan packet, it talks about seizures being possibly exacerbated by Lexiscan. Typically what you would do is if they have a seizure history, it can be resolved with, seizures can be helped by Valium, right? And so in a lot of practices, and this is what we do at our facility, if they have seizure history, we talk to the PA, and the PA will have some Valium on standby. Also, if they're on seizure medications that keep their seizures down, usually that is enough that it keeps it in control, and Lexiscan isn't going to give someone that's on good, a prescription seizure medication a problem. And so that's just one to be aware of and know that Valium can be something that reverses and helps if there's seizure issues. The other one is asthma and COPD can be exacerbated. Albuterol can be really helpful. We usually ask our patients if they have any asthma or COPD history. And then I'll usually ask them if they say, "Yeah, I've got asthma." I'll be like, "Well, how often do you use your inhaler? Are you on daily medications? Like, where's your asthma at?" And if they have severe asthma that's really easily exacerbated, they have to use their inhaler multiple times a day, then oftentimes what I will do is we have inhalers on stock in our department, and I will give them an albuterol. I'll say, let's get do you have any with you? If not, I can get you some. Let's get a couple of puffs of albuterol in you before the test, because it won't hurt the Lexiscan effectiveness, but it's going to help kind of prepare their lungs or pre-treat their lungs in case they get a reaction with the Lexiscan. So that's something you can do. All right. We're going to get into protocols now. So that's kind of both the exercise and the pharmaceutical stress versions. So we're going to talk about a few different types of protocol, and I'm going to start out again with the thallium. Again, you probably aren't doing these. In some areas you may, and like I mentioned before, in particular when we get a tech shortage, we've had times in the past where we've had to use thallium again when we have tech shortages. So we'll go over this. And again, this is good to know for kind of as we start to identify some of the terms with stress testing. All right, so the protocol here is we're going to start. Obviously, we always verify patient prep. I listed that on here because that's just super important with stress testing. So this one's interesting because we're actually going to start by doing the stress test. We start out with the stress test on a regular stress rest thallium protocol. So again, we won't go over the stressing again, but at peak stress, we're going to give 2 to 4 millicuries of thallium. And then post-exercise, remember with thallium, we have 10 or 15 minutes before it's going to redistribute back into the vasculature, okay? So that means with thallium, you have to get them on the camera quickly. We want to get our images immediately. So within 10 to 15 minutes, we've imaged our patient. In terms of the imaging, we're going to be placed supine on a SPECT scanner Arms above the head, because again, we want to prevent your arms from causing attenuation. Images are required centered over the heart at a 180-degree arc. With thallium, you usually have to go 20 or 30 minutes. That's going to vary a little bit depending on the type of camera and your crystals and different things like that. But most protocols are around 20 to 30 minutes. Again, remember the reason we do a 180-degree arc is because of how we image with cardiac. So your camera's going to be in L mode, right? So your camera's going to look like this. And if you think about it, when we talked about that anatomy and we realized what are we focusing on with heart? We're focusing on the left ventricle, right? Remember, the heart is shifted slightly to the left. So the anterior kind of comes out at a 45-degree. And if we're only looking at the left ventricle, you can imagine that to get all the way around it, you really only need to go about 180 degrees. Now, when you have your camera in L mode, and you've got yourself, your patient in there, you're already getting, right here, you're getting a really good septal view. And right here, you're getting a good anterior view, right? So we've started already getting a good septal and anterior. And by the time this goes around 180 degrees, we now have a really good inferior view, and we've multiplied our anterior view again, right? So you've got multiple views. What we avoid is coming out over around on the right side of the patient. And again, because most of our stuff, we're not going to really image the heart much from the right. Because again, we're at the right ventricle in the way. Most of what we're looking at is over on that left side. So that's the reason why you don't do a 360-degree arc typically when you're doing a imaging perfusion on a heart. We do L mode and 180, and we almost get a 300. We get really close to a 360-degree view without having to go 360 degrees. Okay. This can be done as a stress protocol only. Now, why would that be? Why could we do this as a stress protocol only? What I want you to remember with thallium, we're going to do a stress test first, and then we're going to give them that radioactive medicine. If we do an image on a patient, and we'll talk a little bit more about this, but if we do an image on a patient and they come up in our stress test, there's blood flow everywhere during the stress test, then there's no reason to do a rest, because we've already shown that at stress, there's no area of the heart that wasn't able to increase its blood flow, okay? And we'll get a little more caveat of that when we look at images and we compare two images together. But so you can do this as stress, because if you do that stress test and your images pop up and everything looks great, you're good. You don't need to do anything else. Now, for the rest part of a thallium, remember our thallium redistributes, right? So if you image for the 10 or 15 minutes at stress, the thallium went in and you were vasodilated, and so it locked into the cardiac tissue where it was when it was vasodilated. You get images of it, and then after 15 minutes, it washes back in. What that means is you can wait, and usually you'll wait about 3 or 4 hours to give it plenty of time to go through the vasculature again and uptake back into the heart again. So usually after about 3 or 4 hours, you can simply just put your patient back on the scanner. You don't need to give them more thallium, although there are some protocols that will add maybe a millicurie more again after, but you don't have to. You can still get images, but you'll image them again. Imaging will pretty much be exactly the same, but at this point, they've calmed down. The vasodilation has gone back down, and everything's back to where it would be at rest. That thallium gets back into the myocardium, and then you can simply just image them again, okay? The other thing that can happen is what's called viability imaging, and this is something that can be done 24 hours after. I'm not going to explain this right now because we're going to have a whole section in our next lecture about viability, but viability imaging can also be done with thallium, and we'll talk more about that then, so I won't cover it right now. Oh, I will cover this though. I don't know why I put this under Valium, but it can be done in combination with sestamib. So you could do a thallium study for stress, and then you could actually immediately do a sestamib study as well. And you could look at 2 different windows on your camera. So let's look at some pictures. Okay, so you've got your axial view, your horizontal long axis, and your vertical long axis, and the line above is stress, the line below is rest, right? So with this one, what happened with this protocol is you did your stress test, you did it first, and it came up, and you'll notice that there's an area of blood flow that's missing, okay? We don't see it there. And so now the question becomes, is this, and we call what we call, there's a couple of terms I want you to think about. Well, before that, let's just analyze where this is at. So we've got an area that's not getting blood flow. We look down at the rest and it is getting blood flow, right? So that tells us that there is what we call a defect here. When you hear the word defect, what they mean is an area that did not perfuse or doesn't have blood flow, okay? So when they saw this, when they saw that defect, they said, okay, let's do a rest and let's see what the rest scan looks like. So they waited the 3 or 4 hours, came back, and now there's blood flow on the rest scan. You'll hear the term reversible or fixed, okay? So this is what we call reversible. When on the stress scan, there was a defect, and then the rest scan came up and there is no defect there. Or in other words, we've reversed the defect. We started out with a defect and now we've reversed the defect. Now this is where I want you to go back to thinking about when we talk about ischemia versus infarct, okay? This is what we would consider ischemia because at one point there was blood flow there and now that blood flow is not there. So there's a reduction in blood flow compared to the resting scan. Now, I'll ask this question again, and you don't have to answer it, but does that mean that when we did the stress test, we caused an area of the cardiac tissue to reduce its blood flow? The answer is no. We didn't take away blood flow. It's just that because there was no dilation in this area, the rest of it dilated massively, and so we have more of our thallium that went into these areas of the heart. If I was to take my window and brighten it up way high, likely this would fill in. It doesn't necessarily mean, we don't know if it would fill in because we don't have the rest, but there may or may not, there may be blood flow here, there may not be blood flow here. What we're showing is that it's a major reduction. And then when we do the rest, we see that everything dilated, right? Now, the question you're going to immediately say is, well, didn't you say that you could have an infarct versus ischemia, and an infarct is dead tissue? So if I only looked at this stress scan, then you're right. I can't answer the question of whether there's blood flow or not there. Only thing I can say is I see a defect, but I don't know if it's ischemia or if it's an infarct. There's no way of knowing that unless I run a rest scan, right? And when we ran the rest scan, it filled in, which means this is ischemia and not infarct. If it was an infarct, meaning tissue death, no blood flow, then we would see the defect on both the stress and the rest. But because we reversed the defect when we went from the stress to the rest, it means that really what we're seeing here is an area that just is much lower in blood flow. Because again, at rest, it was equal to every other area of the heart. It's just that when we stressed it, it obviously didn't dilate enough to get enough radioactivity in that area that it showed up like the rest of the heart, okay? That can be kind of a funny concept to think about, but just know that that's why we compare a rest to a stress. It's also why if I did this stress test on a thallium protocol, which for the thallium we do the stress first, if I just ran this stress test and it came up and it looked like what this rest looks like, it just was all filled in, well then I don't have a question to answer, I'm done. Because it shows all areas of the heart have filled in. Clearly they've all vasodilated in a similar way because we get radioactivity all the way throughout the cardiac muscle, right? So there's no question to be answered. Once I have a stress scan and it's good, I'm done, right? I can be done. When I get this, then I have to say ischemia or infarct, and I have to prove that, and that's why we do our resting scan, okay? So this next slide kind of shows that. Normal versus abnormal, fixed or reversible, okay? So here's your normal scan. So here's my stress. They all look filled in and beautiful. Here's a rest, filled in and beautiful. Normal test, right? And again, I could, especially on a thallium, I could just do that stress and be done, okay? You'll hear the terms called fixed or reversible. Like I said, I listed those here. What does it mean? Well, in the abnormal category, you can have fixed or you can have reversible. In fixed, again, I do the stress, I have a defect, do the rest, same defect exists, which means I never got blood flow there. And so what we have here is an infarct, right? It's fixed. It didn't change. Over here, I did the stress test. I had a defect. We reversed it, meaning we did the stress test and it filled in. So this is ischemia right here. This is ischemic heart, and it's reversible. So you'll hear people say fixed or reversible. This is one of the reasons I started out with thallium, because when we talk about tech, for reasons that we'll talk about here shortly, you're going to do your rest scan first and your stress scan second on most protocols. And there's reasons why. So let's get into that. All right. So this would be our stress rest sestamibi. And again, this could also be MyoView. This is going to be a 2-day protocol. So for a lot of years, especially coming off the back of thallium, facilities would do this 2-day protocol. So for this one, you're going to verify patient preparation, make sure everything looks good there. Then for this one, you would do the stress first, okay? So you're going to stress patient to whatever, according to whatever protocol. And then at peak stress, you usually would inject about 30 to 40 millicuries of tech, okay? 30 to 40 millicuries is about the ideal dose to get enough counts and to have a really good image that has pretty good resolution. And then what you would do is post-exercise, you would image the patient, and usually you're going to image 30 minutes to 1 hour after injection. Now, remember with the thallium, we had to hurry because we only had 10 or 15 minutes till it redistributes. This is where I mentioned the sestamibi being awesome, because there's no redistribution. It's going to go into the cardiac tissue, what that cardiac tissue looked like in terms of dilation at the peak stress. It goes in and it locks into place. So even though your patient calms down for an hour, it doesn't matter. The cardiolite is locked into that mitochondria where it existed during stress. So it's going to show up that same way. You could image them 2 hours later. I mean, obviously, the longer you go out, your counts go down because you're of decay, but it's going to lock in place where that time is at. I've had patients actually ask me that question, like, how come you stressed me and then you let me calm down? So how am I going to get a good picture as I'm not stressed anymore? Well, it's because we have 6 hours to do that. It locks in place where it was at. Okay. So in this protocol, you're going to do the stress first. You're going to image the patient 30 minutes to 1 hour after injection. Again, remember the reason we wait is because we have to worry about that gut uptake with sestamibi. So we want to make sure that that gut has a chance to clear out, that hepatobiliary clearance, which took somewhere between 45 to 90 minutes, right? So 30, 40 minutes, 30 minutes to an hour later is roughly about it. And then we image the same way. Patients place supine, heads above the head. We're going to acquire at a 180 degree. You're also going to attach your 3-lead EKG because you'll typically gate these studies. And then this is usually like a 25-second stop that goes for about 10 or 15 minutes. Don't get married to that because it depends on your camera and how your camera works and things. And there's what type of collimator you may or may not have. There's some collimators that focus in on the heart. So don't get married to that, but probably somewhere between 10 to 15 minutes is what you're going to image with this. Now, notice this is a stress first protocol, just like with the thallium. So again, if we pull up our images and we get a heart that's totally perfused, well, guess what? You can be done. Sweet. Patient can go home. You've answered the question. There's no defects and you're good to go. However, if there is a defect, now you're in trouble because you've got a 6-hour half-life, right? That's why this one used to be a 2-day protocol, because if you stressed them with 30 to 40 millicuries, you have to wait too long to actually image the patient again. Because even at 6 hours, that's only half gone, right? At 6 hours, you're half out of the system. Well, that's actually sort of like 3 hours, you're halfway out of the system because the biological half-life is 3 hours. But you get my point. You can't image the rest of that day because you're still going to have your sestamibi in there and looking like stress and giving off a lot of radiation, right? So this is why the patient would have to be brought back the next day if they had a defect. So again, they did this at first because you could just move on if you didn't have a defect. But if you did, you have to bring them back. So bringing them back, you would inject 30 to 40 millicuries again the second day. You would image the patient the same way you did before, and then you could have those images and compare the two. So that's the 2-day protocol. So advantages and disadvantages were kind of a big deal as to why you don't see this a lot anymore. Some places will do this, But the advantages, obviously, is that it allows the full dose to be used, right? You can use 30 to 40 millicuries and get really good images on both your rest and your stress. This would allow you to omit the rest images altogether if the stress was normal, which obviously saves the patient time, and it also, more importantly, saves them exposure, right? Their dose goes down. Disadvantages is also patient inconvenience, because if they needed to come back, now they're having to come to the hospital 2 separate days. Then you run into work schedules and all kinds of things like that. And then also timeliness of results. This takes 2 days to even complete the whole entire protocol. I've heard of stories where people did this kind of stuff where the patient just didn't come back. And so then you've got this stress scan that's abnormal that the doctor is like, how am I going to read this? I don't have anything to compare it to. We don't know what it is. I don't know if it's ischemia or if it's infarct. And so there's problems like that with a 2-day protocol. So these aren't very popular. There may be some areas out there that do it, but you probably won't see this a ton, and that's why. But you can see where people who were used to using thallium kind of adapted this protocol at first, but we developed some better protocols. One of them that people would do to try to make this work is a dual isotope. So they would use thallium and sestimibie. And so basically with this one, and I won't read over every one of these, but basically you would do like a resting thallium scan, and then you would follow it up with a stress sestimibie scan. The reason that can work is because, again, remember, and I've kind of bolded these, that 69 to 81 keV, we can set a window on our camera to look for that energy with thallium. And then no matter how much thallium is or isn't in there, we can then set our window for 140 and just look at the sestimibie. So you can separate your imaging out that way and get it all done in one day. So that's one that was adopted for a while, and you may see that in areas. You may also see this done when you have a shortage on tech, right? Because tech has a much better image. It's much better image quality. So they say, okay, well, the stress scan is kind of our one where we determine if there's a defect or not. So let's get a really great picture on that. And then our rest scan, we can stand that to be a little bit lower image quality. And so we save some of our sestimibie when we're on a shortage, right? So that's another reason you might see a dual isotope imaging. Here's some pictures of one that was done. So this is our stress and our rest. And so you see that a defect in here, and then it fills in. So again, this is reversible. So some good images to look at. All right, so stress rest 1-day protocol is kind of the most common thing that you'll see today. There could be some variation, but I would rule into bet most of your facilities probably do a 1-day protocol. So the 1-day protocol, again, start by verifying patient information. We're going to start out with our resting scan. So with this protocol, what you'll notice is that the way we're able to work through and get something using sestimibie the same day is we're going to use an 8 to 10 millicurie dose on the rest, and then we're going to use the standard 30 to 40 millicurie dose on a stress, okay? And you might ask yourself, well, wait a minute, how does that work? Okay, and this is what I would point you to. Waterstroms calls this the principle of being, they call it overridden. What I've heard most of my time, and I see techs say, is they'll say shine through, okay? What shine through is it's detection of radiation from a second source. Let me say that in a better way that's not so textbooky. As you guys know, think for a minute of just doing, let's say, a HIDA scan, right? And you see that gallbladder start to fill up, and you're like, okay, I can start to see it. And you see a little bit of somebody had a question.
Why'd we get rid of Sweeto Burrito for another chicken place?
Somebody is not muted. Hey, can everybody mute? Somebody's not muted. Okay. All right. So think of that gallbladder, right? So when you have your gallbladder, you can take your windowing, and you can, if you first start seeing it, maybe you can't quite see it good, you can take your window and brighten it up really and make your gallbladder really bright, right? However, if you keep getting brighter and brighter and brighter, that liver that's sitting behind the gallbladder is eventually going to show through, and you can't see your gallbladder anymore, right? And what that means is that your gallbladder has the most activity, but that liver underneath you don't see as well initially unless you brighten it way up. What's happening there is your camera, it detects the hottest pixel, and then it makes all the shades of gray go down. That hottest pixel is white, and then all the shades of gray down to black are represented from less radiation all the way down to black, usually being kind of no radiation or some version of that, right? So the reason we can do this is that we'll do a resting scan with 8 to 10 millicuries of sesame. We'll image the patient with that. And then what happens is when we give 30 to 40 millicuries, which is about a 3-fold increase, even though there still could be some of the imaging from that resting scan in there, what happens is the stress dose overpowers the rest dose, and the camera equals itself to the hottest pixel, which would certainly be part of stress, right? Because we're using so much more of the sesame. It will level itself to that, and then it means that you won't see that resting dose shining through. So that's how it works. And we call that shine through. You won't get anything shining through because the dose is so much greater. So that's why in this situation, you see an increased dose, or you see a decrease of dose in the resting scan. Now, you get ideal pictures on a SPECT camera with sesame from 30 or 40 millicuries. That's when you get the ideal amount of counts. So what you're doing here is you're sacrificing a little bit of image quality on the resting scan so that you can do this in a one-day protocol, okay? We want our stress to be the one that gets the higher dose so that we can have really good images on stress, because again, the stress is the one where you may or may not have a defect. It's really your most important image to kind of determine everything, but we still have to have the rest to compare to, and so you'll have a little bit smaller dose there. Now, as you can imagine, besides those two differences, it's mostly similar protocol to what we've talked about already, right? Inject the patient, image 30 minutes to 1 hour after injection. Again, hepatobiliary clearance. You can image this immediately. We'll talk about some caveats in a minute. Let me just get through these bullet points. But patient should be placed supine on the SPECT camera, arms above the head, for we don't want attenuation of the arms. 180-degree arc, typically for somewhere in the neighborhood of 10 to 15 minutes, again, depending on your camera. And then we're going to exercise the patient according to whichever exercise protocol. At peak stress, we're injecting 30 to 40 millicuries in. We're waiting our time for hepatobiliary clearance, and then imaging again. Usually you'll gate the stress scan. Some places I've seen gate both. Really, your gate is going to be a resting gate either way, because likely your patient's pretty calmed down by the time you do that, but it still gives you ejection fraction and some of those things. Okay, so the caveat I wanted to bring up here and that I wrote on both of these is that it can be acquired immediately. And I'm betting right now that all of you are thinking in your minds like, wait, my texts don't wait 30 minutes to an hour, or maybe my texts do, or my texts say all these different things. So any of you heard something different than wait 30 minutes to an hour? Or maybe
I've heard multiple different times, so it's kind of hard like figuring out what I should do as a tech.
Yes.
Because some techs would go immediately after we've injected for the rest, and some would wait 30 minutes.
Okay.
And then another thing I wanted to add was we add lime juice to our water to have them drink, and
Okay.
it will help separate the stomach more.
Okay, cool. I hadn't heard the lime juice one, but I have heard of drinking the water, but that's cool. Lime juice.
Yeah, kind of helps with the images.
Yeah,
So it's
cool.
been
Thank
good.
you for sharing. Anybody else? I'm gonna talk about this. Thank you. All those things are good things. We're gonna talk about principles, because I love how you asked. I don't know what to do as a tech, and so what I want to do here in this little discussion is get to the purpose of what we're after. But anybody else have things they've seen that are different than this? Okay. Probably no one wants to talk. I bet you have, but you don't want to talk, and that's okay. I don't care. Okay, so the reason I want to bring this up is because you're going to see a lot of different things. But the question I want you to ask yourself as a tech is, what am I trying to do? Right? What am I trying to do? And the main thing that you're going to run into with this, and let's see if I think my next picture might have something. I won't go over those right now. You can look at those later, but let's get to what we're talking about here with pictures. I'm going to go to some of our last pictures real quick just to talk about this since we brought it up. The main thing, the reason why that 30-minute wait or that hour-long wait is there, it's because of hepatobiliary clearance, okay? So this is a scan that was done, and you've got your stress on the top, rest on the bottom. So here's what happened. This tech imaged this heart, and they imaged it right away. They did not wait. You can see the rest scan. If you were to look at this rest scan on its own, you might look at it and go, wow, I can see this huge amount of gut, right? So this is your hepatobiliary clearance. This is your gut uptake that everyone talks about. And it's like, what this makes it look like, it's obvious because it's gut, but it makes it looks like your heart is really underperfused. And what's worse is I really can't see this kind of inferior lateral wall. I can't see it at all. It's kind of non-existent because that gut is so strong. This tech was being lazy. I'm going to be frank with you, because they didn't do anything about this. They just went ahead and stressed the patient, and look at the stress. They ended up with basically the same thing, right? There's a little bit of separation here. Like, it's not as bad as the rest, but it's hard to determine everything with looking at this. It's really hard. There is some separation, but it's kind of bad. So when you ask yourself, what do I do as a tech? What I want you to do as a tech, what you need to do as a tech is say, I want to get good images. What I want to do as a tech is produce images that don't have gut and don't have a problem. They're quality images. So my answer to this is do whatever you need to do. So some of these secrets are what you mentioned, right? Like, if you pull up your rest scan and it looks like this, there's multiple things you can do. One of the things you can do is simply just wait a little bit, right? So again, that's the reason we have the 30 minutes to an hour of clearance. The other one you mentioned, you can give them some water. On a rest scan, we don't typically want to give them anything with food because we don't want to stimulate the stomach. So I don't know about the lemon juice. I hadn't heard of that one before, but I've heard water. Also movement, right? Have them walk the halls for a little bit. Have them do that. But don't just continue on until you can try to do something about that gut. Now, there's other things we can do on a stress that are even better, but on that rest scan, you want to make sure you do something. Now, my advice that even better than that is when you put your patient under your camera after you've given them the rest dose, you can go ahead and put them under immediately. If you don't want to wait, put them under there. Don't start the camera, don't do any CTs, but you typically have a window on your camera where you can start seeing counts, and you can set that up to where it gives you a buildup of counts, almost like an image would. Just look at it. Oftentimes, by looking at it, you can see if there's a big amount of gut that's coming up into that cardiac tissue. You can see if the liver is really, really highly perfused and it's going to cause a problem. And so I would say just throw them under there and take a look before you actually turn on your camera. And oftentimes you can get a good look as to whether you have separation and whether the image is going to be okay. And hey, if it looks like there's not a bunch of gut uptake, image. That works. Go ahead and image. Because why wait when you're getting good images? Again, the only reason we care about the hepatobiliary clearance, or excuse me, the only reason we have a delay in the protocol is because we want to get rid of that gut uptake. But if you don't have it, then hey, let's image. Makes everybody's life easier, makes your scan faster for the patient, right? When we get to stress, I'm going to do the same thing. I'll stick them under the camera and take a look and say, okay, is my gut uptake gone? Awesome. If it's gone, sweet. Let's move on. If it's there, then what's advantageous with the stress is, remember, when I inject a patient at peak stress and that radiopharmaceutical goes in, it's going to lock into the cardiac muscle where it was during stress, and it will stay there no matter what happens after. So what's beautiful about this is if your rest is okay and then you get your stress up and you have gut uptake, you can go ahead and give the patient food. Food works awesome to like get the stomach active and moving radiopharmaceutical out of the area, right? You could have them go eat. Go grab some lunch and come back and see me, and I guarantee you're going to get way better pictures. And the reason we can do food on the stress is, again, because we've already stressed, we've already put the radiopharmaceutical in there, we've got nothing else we need to do. You don't want to do food on the stress because you'll then make the stomach, you might get some clearance of that, of this lower gut uptake, this inferior gut uptake, but then your stress is going to look terrible because now you've activated the stomach like crazy, right? But I've heard things from, milk, water, the lime juice is one I hadn't heard before, a myriad of things. But again, the principle as a tech is just do what it takes to get a good image. The protocols are there to try to guarantee an image. You can go off those protocols as long as you get an image that is accurate, good, and doesn't have gut uptake, okay? That's the main thing I want you to think about with that. This next image, let's see, did I do that one? We'll get to more of that. That's your idea. I'll show you some corrective action ones in just a minute, but I want to get back to some of the stuff we skipped. So advantages and disadvantages, again, patient convenience, they only have to come one time. Timeliness of the results happens quick. The one disadvantage is you're going to prevent that shine through, so the rest dose is reduced, so your image is a little, not quite as great, but it's hard to tell that much. It still looks like a great image. And then reduction of dose is obviously a good thing. Or, well, this is reduction of counts on the rest, which is what I just said, but we reduce the patient dose a little bit as well when we do it this way. Okay. So the other thing I wanted to mention here is just kind of since we're talking about it, and this is kind of a sidebar, we've talked about this before. We talked about it in our last, not our last class for this semester, but in our physics and instrumentation is spec attenuation correction, okay? So this is what the attenuation correction software looks like when I pull it up on our spec camera. Yours may look slightly different, but the principle is going to be the same. It's going to have a CT in the background and your perfusion in the foreground, and it's going to allow you to move them, right? Because what you're wanting to do is line them up. So what I did is I moved this one on the left out of place, ridiculous. Like here's the CT of the heart right up here, and I moved the perfusion way out. You'll probably never get something that the computer brings up quite this bad, but I have seen some gnarly ones. So again, what you're going to want to do is you're going to want to move this perfusion right over the CT. This will move up. This is going to move kind of to the lateral, and it'll probably move a little anterior. And that's what I've done on the second set of images. And you can see that they're lined up much better. And we always want to make sure our attenuation correction is lined up, because that's the other thing that can make a defect look terrible. If I processed my images with the attenuation correction here on the left, it's probably going to make it look like there's a big defect in most of the heart, except for maybe this inferior septal wall. It's going to probably look okay there, and it's going to look terrible the rest of the heart. So again, it can affect it, and I showed you some of those things last semester as well, but I just wanted to remind you and kind of put that caveat that if you're using CT, it's very important to do the attenuation correction. Here's just some general good-looking slices of it. This is a stress rest protocol for sesame. You can see that you've got perfusion all throughout the myocardium and all the slices. It's a beautiful scan. Scan's totally negative, looks great. The other thing I want to mention, so we're going to mention, when we do PET, I'm going to go over more ancillary data that will apply to SPECT and to PET, and so I've saved that for the next one. But I do want to at least mention polar maps, because this is where you start to remember earlier I mentioned knowing where your coronary arteries are located and what they're perfusing will help you as you look at images. And so what a polar map is, you'll see that when you process and you come up with your images. But essentially, remember earlier I talked about the cup, right? So if I took that cup and I pressed it onto a flat map, I don't know, I did a little. I was in Cub Scouts when I was younger, and camping, they have those collapsible cups, right? It kind of reminds me of that. If I were to kind of collapse everything out flat, a cup-shaped flat, that's what you get here. And so what you're seeing on this polar map, it's divided into 16 segments on the map. And then each segment is giving, in your software, is usually given like a 4-point value, and it will show reductions in blood flow on these maps to kind of help you see where the defect is taking place. But it's named according to anatomy, right? So you have like your anterior, inferior, septal, and lateral. So you'll see things like, for example, this one out here is called basal anterior. So it's at the base of the heart, because remember, if we flatten it out, our apex is in the middle, and our base is around the outer edge, okay, because we've flattened that out, right? So all of these will be anterior, but you're going to have basal, mid, and apical, and that'll work that same way all the way around. So anything out here is going to be called basal, because it's the base of the heart. Anything in the middle is going to be anterior, but again, it's going to be based on, for example, so over here on 6 and 5, if you come down, you'll see they're basal, but they're inferior, they're lateral and inferior, right? Number 4 is going to be basal inferior. 10 is going to be mid-inferior, and then 15 and 17 are going to be apical. And so that's how it works. So you're looking at that in that way. The other polar map that you'll see show up besides this is a polar map that identifies based on the coronary arteries, right? So you're going to have your section that shows you the LAD perfuses, what the circ fuses, and what the RCA perfuses. And remember, I mentioned LAD perfuses anterior to septal. Circ is kind of your lateral, and it also goes inferior, and then your RCA is kind of inferior to septal. So that's what you'll see too. So when you look over here, that's essentially what these are identifying. So if you look over here and you have, let's say, okay, so you've got something in like 5 and 11, you have a defect that would be in 5 and 11. You look here, you could identify those as baso inferior lateral, and 11 would be mid inferior lateral. And if I said, what coronary artery is that likely going to be? You would say what? Circ, right? Circ. If you had something where it was only, your defect was only out here during the base, what you could probably say is that, or excuse me, if it was only, I said that wrong. Let's say it was only apical, right? It was down here at 17 where you're kind of seeing it, maybe like 16. What you could assume then is you could probably assume that it's coming from the circ, but you could assume that it's not up by the base. It's not at the top of the circ. It's going to be way down lower, right? Because that's more towards the apex. So your blockage is probably down farther down the circ because you're only getting your defect here. If you had something blocking at 5, you're probably going to see your defect go all the way through all of these, right? Because if you're getting a blockage way high, it's going to take out the whole artery. And so you start to kind of see as you look at these polar maps how I can identify what I'm looking at, and I can start to identify likely where the problem lies, okay? So that's what I want you to think of as you look at these images. So here's some polar maps right down here. These are the ones that are divided according to the coronary arteries. And so again, what I would ask is as you look at the images up here and you see a defect, and you look at these polar maps, anyone want to be brave and tell me what their opinion is of what coronary artery might be involved here?
Would that be the LAD?
Yeah, yep, it looks like LAD to me. And do you think that it's high up at the beginning of where the LAD comes out, or you think it's down further a little bit?
I believe down further,
Yeah.
maybe a little
Why do
bit.
you say that? Sorry, I'm picking on you.
No, you're okay. Just because the center of the circle is the apex, and
Yeah.
then like the outer side is the base of the heart.
Yeah.
So since it's not touching the base, it's closer to the apex than.
Yeah, exactly. Exactly. Yeah, you're noticing that you're getting perfusion at the base, so there's got to be blood flow coming partially down that LAD somewhere, right? It's coming down, but we don't know for sure. Now, what would be interesting if this defect's pretty large, if it were kind of small and located perfectly apical, it might be a little more of a question because you don't know. You're looking at this and you're like, the circ over here could be involved there as it swings down and comes around. Most likely it's still LAD, which is why they do this little half circle. But it can get, the smaller that defect gets towards the apex, the harder it can be. When it's out towards the base, it's much easier to kind of figure out, right? So good, very good. Okay, let's see. We've already looked at that image. So here's another one. So here's stuff broken up into the 16 segments. Oh, and actually, this is what I want to show. This is good for looking at the polar maps, but also for looking at what happens here when the tech didn't take care of the gut uptake, right? So these are the same. This is the polar maps from this one where we looked at the gut. And if you look at the rest here of the polar maps, I mean, this makes it look like you've literally lost your entire LAD, part of the circ, part of the RCA. I mean, this looks pretty ridiculous, and obviously it's because it's not real, right? It's that gut uptake. The only thing you're seeing is the gut uptake, and causing those problems. And then here's where you can see it divided into those 16 segments. So right here, you'll notice where it's giving it a point value. So all of these areas in green are marked 3. Right at the apex, it's marked 4. So you go from 1 to 4, 1 being the least defect and 4 being the greatest defect, is what they typically do. And so that's another visual way to look at that. But again, you can see the problems and you can see how those are all divided out. Okay, I want to get to this one because this is where we kind of talk about doing what's right and correcting the problem, okay? So our top line here is the rest, and then we have two separate stresses underneath. So this tech did the resting scan. I'm gonna guess this was done right away because of the gut uptake. You'll notice on here that I don't know, I found this one, I'm not sure who did it, so I didn't talk to the tech. But you can see on the inferior wall and where the gut is here, you can see that there is some separation there. And this is kind of where a tech probably just made a call and they felt like they could see it good enough that they decided to move on to the stress. I will tell you, you should have waited on this one. Now, there are times where you wait 30 or 40 minutes and you give your patient a drink and it still comes back looking not great. And sometimes you have to just take it. You just have to go with what you can have. Everybody's physiology is different, their anatomy is a little different, and so you have to take it, right? But if I saw this exact picture, I'd probably try to do all those things. So we'll just give this tech the benefit of the doubt and say they did all those things, okay? So we moved on from our rest and we went on to our stress. Now look at the stress. The stress looks terrible. It's much worse. You don't see any separation, and the counts, the way the computer is averaging out the counts, there's too many counts that are being stolen down here by the gut. It's making this heart look terrible. It looks like we have reduction in blood flow in almost the entire heart compared to the stress, which we can assume is not real, or at least we can't rule it out because that gut's sitting there. So this is an example of one of those where what they did is they waited. They waited, I'm assuming probably gave some food as well, and then came back later and we redid the pictures. And notice you still do have a little bit of gut, but notice how much better it looks. You can clearly see a separation between what's gut and what's the myocardium. And this is what you want to do. This is what it means to be a good tech, and to go and to get the pictures that you got to get and to do the best scan you can. Again, would have been ideal if we could have got a better rest scan, but what's nice about this is this stress scan looks good. We have a separation, and you'll notice that the entire cardiac wall's filled in. There's no defect. So we've at least answered our question that this is a normal stress test, right? It looks great. This is diagnostic. All right. And I think that's it. That's all I got for you today. We'll do a bunch more next time, but hopefully I'll let you just get out of here and get to Brandon's class. If there's anybody that wants to stay and ask a question, I'm happy to do that. But if you guys want to just vamoose to the other class, I'm cool with that too.
Thank you.
You're welcome.
Thank you.
Welcome.
Thanks.
Have a good day.
You too. I'm going to hang out for just a second in case any of you are sticking around. Once I see y'all gone, I'll end it. Or maybe I should just ask with the few of you remaining. Do any of you have any questions? Or are you waiting to see if there was questions? Okay. No one's saying anything, so I'm going to assume that none of you have any questions. So I'm going to end. So speak now or forever hold your peace, and then I will see you next time.